So somebody who can who's an expert, nationally and I think world-renowned expert on treatment and has been working in this field for many years is Lucy Berliner. She's the director of the Harborview Center for Sexual Assault and Traumatic Stress. She's also a clinical associate professor at the University of Washington School of Social Work and the Department of Psychiatry and Behavioral Sciences. She's got a CV with many, many, many research grants, a long list of research articles, and a long list of book chapters, which means that people are coming to her and asking her to contribute to integrating information. She's well known for being an expert on what works and how to treat child sexual abuse survivors. She was awarded earlier this year a Distinguished Career Award from the International Society for the Prevention of Child Abuse and Neglect. Lucy Berliner.
Who's missing their phone? Margaret. All right. Well, there's a phone. Good morning, and it's great to be here. As I think all of us and I are so impressed with what Penn State has chosen to do under these dire circumstances that have been faced. And in a way, I kind of think of it as basically the dilemma for, or the challenge for all victims, which is you can't really change the past, but you can change the future. And that is what we see your university choosing to do with this situation. And I have to say, I really admire it and feel very honored to be able to participate in this process. Now, I knew this would happen. Dude. Oh, see, just trying to make you crazy. Two exactly the same looking things. Okay, so as you have already heard from everybody so far, sexual abuse is a lot of different experiences. We heard already from 3 different survivors who've spoken from here about a coach, about a neighbor, about a childhood friend's father. We heard from Penny yesterday about intrafamilial abuse. This afternoon, I believe we'll be hearing from Elizabeth Smart about a random stranger coming in a bedroom and kidnapping her. In our clinic, almost all the teenagers we see have been raped by acquaintances or dates. Yesterday, David Finkelhor talked about the so-called compliant victim, or victims who don't really even believe that what happened to them was wrong or a victimization. So for starters, it's very important to recognize, and I guess to echo what Margaret and Chris said this morning, that sexual abuse is a lot of different experience. It's an individual experience for each victim. But in addition to the tremendous range of experiences that comprise sexual abuse, of course, every victim comes to their experience of victimization with a different background, a different set of experiences. Some kids have families like Margaret described, who are there for them, who are caring, and a lot of other victims do not have that background. They come from harsh circumstances where parents are troubled or overwhelmed, or where there's violence, or there are a lot of other things going on in their lives. Kids are from very different circumstances developmentally. We've just heard Julie talking about these little tiny kids, teenagers, everything in between. And something that hasn't been so much talked about that's very relevant to the impact of victimization, and that is what it was like in the moment. Even in the experience of victimization, what it's like for the victim can be very different. Some people are scared to death, some are confused, some don't really know what's going on, don't even know it's victimization. So this diversity of experiences and individuals, it shouldn't surprise anyone that there are many different outcomes from sexual victimization experiences. I mean, it only makes sense that that would be true. And we have hundreds and hundreds of studies now, some of them of the very high quality that Penny described, that the study that she and Frank Putnam have carried out, where they've been able to follow children forward throughout their lives and document all kinds of things that have happened to them. And one thing we don't have are studies that show that when you compare children who've been victimized to children who haven't, it doesn't make any difference. When you compare the groups, it always makes a difference to have a victimization history, sexual abuse or otherwise. And almost every outcome that's been examined, whether it's psychological effects, whether it's economic effects, whether it's being at risk for other bad things to happen, it always makes a difference, and not in the good direction. That won't surprise you. But it's not a universal impact, and this is all a lead into providing a foundation for why one size fits all could never possibly be the best fit for victims of sexual assault or any other bad event. Many people might be familiar with the ACEs study, the Adverse Childhood Events Study, and it's just one of many but it's a very well-known one, that has made a point that is one that is more and more how we all think about and try to understand the impact of bad things that happen to kids along the way. And it turns out it's not so much just having a bad thing, but it's the piling up of bad things that really makes life harder. But even if it doesn't necessarily lead to a terrible outcome in a given case, and I think it's very important to keep in mind both what David Finkelhor talked about from the very academic perspective and what we've seen from the survivors who've spoken to us, you can be affected without being ruined. And I've thought about this very often in the sense that one thing we sometimes go down a pathway of measuring the badness or wrongness of victimization based on how harmed the person is. And really, the two things are completely different ways of understanding the effects of victimization. We shouldn't require victims to be harmed permanently to receive our acknowledgement, our validation, our recognition that their life has basically been made harder by this experience, however it happens to turn out in their particular life experience. Now, you've heard throughout that when we're looking at psychological impact, and that's what we treat when we're providing a therapy, we're not basically treating people and we're not treating events. We're treating specific psychological conditions that we hopefully have a therapy that works for. So the most common psychological conditions that sexual abuse victims and victims of other traumatic events experience are post-traumatic stress disorder and depression. They commonly go together. Maybe 70% of people who have PTSD will also have depression and other types of anxiety conditions. As Julie mentioned, PTSD is a special case of anxiety. You think about what an anxiety disorder is. It's having an unrealistic or extreme fear or worry about something that gets in the way of functioning. And in the case of PTSD, essentially what the fear or worry is about the memory. So it is the only trauma-specific psychological condition, meaning you have to have a traumatic experience to get PTSD, because the psychological characteristics and symptoms of PTSD relate directly to the traumatic event. When I think about depression, of course, there's a lot of ways to get to depression. Depression is a pretty common mental health problem, and you can get it for lots of reasons and no reason at all. In the case of trauma, how I think of it as being connected is through how people think about what happened to them. Now, as you can see, PTSD and depression are the most common psychological outcomes, but most people never actually get them or develop the symptoms that would lead to the diagnosis. So while it's common, a third of people developing a psychological condition from an experience is high, it's by no means universal. Now, the two main things I think are, and I'm a boiler downer. I'm always trying to get a handle on things in as simple and specific a way as I can. And partly why I find that to be helpful is because the type of therapy that I practice, in addition to all that other crap that he was talking about, I also have a caseload, and I provide direct therapy services to kids and adults. We are a clinic that specializes in helping people who've had bad things happen to them. And the type of therapy that we do is one in which we believe that we're in a collaborative relationship with our patients, and we try to take a very transparent approach to everything we do. No smoke and mirrors, nothing, no magic. And if I can't understand and explain our concepts and ideas in a way that ordinary, regular people can understand them, how helpful is that? So I think of the big trauma-specific impact, psychological impact, as partly being the memory itself of the event. The images, the sensory aspects that go with remembering. We like to talk about it in PTSD as a memory with the volume turned up way too loud. So in effect, when people think about it when they don't want to, they're reminded of it, and it's not just like an ordinary bad memory. It's a bad memory that's coming right with all this negative emotional association. And that, of course, not surprisingly, is very uncomfortable, painful, disturbing, and all of that. And as Julie pointed out, something that's extremely important in understanding PTSD, which is avoidance. You don't have PTSD if you're not trying to avoid that memory, because it's so unpleasant and so uncomfortable to have those kind of memories that people will do a lot to avoid it. Sometimes they do things on purpose to avoid it, avoiding situations, people, things that remind them. But a lot of it is less conscious and specific than that. Some of it is numbing, shutting down, dissociating, all that kind of not feeling things, so you don't have to be and have the feelings of the memory inflicted upon you. But the other part of PTSD, or trauma-specific effects, depression and PTSD, has to do with what people think about why this happened, why it happened to them, and what it all means about who they are and who they are in the world. and how they connect to other people and the world. And it's amazing, as you have heard throughout, how an experience can have such a powerful impact that lasts for so long about who I am. And of course, we all we understand that, and generally, it's not really great thoughts about who you are and your place in the world. These are the very typical kinds of beliefs that victims end up with. I deserved it, it was my fault, I could have, should have, I'm ruined, I'm disgusting, I'm gross, people are dangerous, they're out to get you, you gotta, watch out for people, all of these kinds of beliefs. I mean, it's just common sense, right? If a person is thinking any of those things, they're not gonna be very happy. They're not gonna have positive moods and emotions, and it's very likely to lead to behaviors that are, might be functional in some ways, but are probably gonna interfere with getting along in life. So when we're doing therapy, these are the things that we're concerned to focus on and do something about. Loud, negative memories and thoughts that aren't true or aren't helpful. That's the essence of effective trauma-focused therapies. Now, we have really excellent news. You've already just heard from Julie about an effective, proven treatment for little kids. So I'm talking about the effective, proven treatments for older kids and for adults. Now, these treatments look quite a bit different than the one that Julie was describing, and they're developed based on a little bit different theoretical perspective, and they're targeting obviously quite a different developmental stage. But all of the things she talked about are exactly what we do in trauma-focused CBTs. We are teaching patients or clients about the connection between thoughts, feelings, and behaviors. We are giving people skills to manage negative emotional states. We're helping them develop a new and better way to think about what happened to them. So we're going after the same things, we're doing it in kind of a little bit different way. Now, the trauma-focused CBT with capital T, capital F is, and should be, pretty well known to you guys, because the people who developed it live in Pittsburgh, and it's an amazing intervention that's been disseminated all around the world. And there have been variations on that theme, small t, small f, trauma-focused CBTs with a little bit different names that have been developed and tested in all over the world. I mean, it's just a fantastically impressive outcome that we're seeing. Just to give an example, I've got some young colleagues, and practically everybody is younger than me, so I guess all my colleagues are younger, maybe except David Finkelhor, and he's left. But these young gals are teaching people, local health workers in sub-Saharan Africa, to deliver trauma-focused CBT, for example, to sexually abused HIV-positive girls in Zambia. And it's unbelievable. These kids in 12 weeks are going from having PTSD to not having PTSD. Now that's wild. Dr. Laura Murray from Johns Hopkins has an NIMH grant that she's just finished demonstrating that. Dr. Shannon Dorsey from the UW, University of Washington, it was in Tanzania last week. I've met her Tanzanian colleagues who have been treating AIDS orphans with this intervention. And they were in Cambodia just within the last year. So this is a really neat little intervention that in a relatively short period of time can help people go from having a psychological condition to not having it. The results are extremely impressive. The same exact treatment approach, these trauma-focused CBTs, work with adults who were abused as children. Cognitive processing therapy, for example, another variation on this theme, has been shown to work with adult survivors. Personally, I have, just within the last 7 or 8 months, seen a woman who was in her mid to late 30s. She had been abused by just many, many different people during her childhood, and she'd had PTSD for 20, 25 years, and she came in and participated in this therapy, and in 4 months, she didn't have PTSD anymore. So I'm a big fan of the impact that this intervention can have on people. Now, the essential ingredients of this treatment, why we think it works, is it has 2 main things we're doing, and they relate right back to what I was describing in terms of the things that really matter about traumatic events. And one is the memory itself, and the other is the beliefs about the experience. So the first thing is facing up to the trauma, facing up to what really happened, and finding out you can live through it. People are afraid of their feelings so often when they have PTSD. They believe that they will be destroyed by facing up to their feelings, or will decompensate, they will fall apart, they will not be able to survive their own feelings and their own memories. And we teach them that they can do that. Now, that's in psychological talk called exposure therapy. And I have to say, you have to actually believe in it to do it. So I have many, many times had to essentially give a rationale, provide an argument for somebody and it goes something like this. Well, this might seem really weird, but remembering on purpose is actually going to be the cure for these memories that are bothering you. And that's what we're going to do in therapy. Or I might say something like, you've heard of people having a fear of flying, right? Have you ever heard of anyone getting over their fear of flying by not flying? So I would say the toughest part of trauma-focused therapies is the therapist having the confidence and the belief that facing up to the trauma in all of what it is will actually be helpful to people, even though, by definition, when the process starts, it's really hard and really distressing. Because that's what PTSD is. If the memory wasn't really bothering somebody, then they wouldn't have PTSD. So probably the biggest initial hurdle of doing trauma-focused therapy is the therapist. And I do a lot of work, sort of the thing besides doing therapy, the thing I'm most interested in is raising the standard of care for regular kids who have traumatic experiences, who are going to get their care in public mental health. They are not going to be going to a university specialty clinic. If that's all we've got to offer, not very many kids are going to get the care they should get. So I want to go to the place where most kids are and help the therapists do a better job of helping their clients. Because now, this might seem awfully weird. It certainly seems weird to me because I've spent my whole career in trauma therapy. So it's, the idea of talking to somebody about a bad experience they've had, that's just like what it is. But one of our first barriers, and it's just been amazing to us to find this out, that for a lot of therapists, even asking kids, have any of these bad things ever happened to you, is something they can barely do. Now, we actually say you should be doing that right away, right from the beginning. In our clinic, when a new patient comes in, they get handed a piece of paper with a list of traumatic events in which they're asked, has any of this ever happened to you? Do you have any of these symptoms or emotional reactions? Now, we are a specialty clinic, so people they come knowing they're going to talk about that. But one thing we've learned, that what brings people in the door isn't always the thing that matters most, that most of our patients have multiple trauma experiences. So before I ever even meet somebody, they've already filled out a checklist describing the traumas that they've been through, and they will walk in the office and say, hey, they told me to give this to you. I have not once had someone fall to the ground in the waiting room because someone asked them, have any of these bad things ever happened to you? People actually are so happy that you ask, that you care, that you're interested, that this idea that you have to wait until you have this long, complicated relationship with someone before you can ask them about these trauma experiences is, in our experience, the exact opposite of what is most helpful to a trauma survivor. What is really helpful is for them to find out. People have heard about it, people are interested in it, and people can handle it. And if you won't bring it up until they do, or you don't bring it up until you've gotten to know them for 3 or 4 months, you're sending a message. And the message is, I'm not interested, I don't want to hear about it, I don't want to know. Well, they wouldn't be needing therapy for their traumatic event if they weren't already living with the idea that other people and I can't really handle this. So that's our first task with public mental health, is to say, ask everyone about their trauma experiences, because they will tell you. And it's really kind of funny the way they want to argue with us about how that really isn't true. And so that's their very first exercise they have to learn. So that's the beginning of exposure. That's the beginning of the exposure process. The facing up is to start right away with being able to talk about it. So I like to use David Finkelhor against the therapists, because when he talked about some of the studies he's doing and other colleagues, you know how they're finding out about these trauma histories in all these kids? They have like college students who are not mental health professionals, who are trained to follow a computer-assisted interview schedule. And they call up kids. Remember he talked yesterday about studies with kids as young as 10 answering questions? That's cold calls. That's random digit dialing. Somebody calls them, says, we're doing a survey. Could we talk to you about bad things that have happened? And, oh, but could we talk to your kid? And they get on the phone, and I'm not kidding, 60% of kids will say, this, that, or the other thing happened to me last year. Now, if a stranger college kid following a computer-assisted interview can invite a child to talk about their experiences and the child will respond, I would say that suggests that this business that we in the therapy business need to wait for months might be a little bit talking about ourselves and not very much about the patient and the client. So all of trauma-focused therapy is about facing up. Not just the talking about in detail about the experience. And it turns out, which is pretty interesting, and you can see it in the adult trauma therapies, there are 2 main evidence-based therapies for PTSD for adults. One is called cognitive processing therapy, and the other is called prolonged exposure. They're both cognitive behaviorally based. They're both structured. They're both relatively brief. They're the 2 interventions that the VA basically now supports for wounded warriors. And they look completely different because they come at the exposure to the trauma in quite different ways. Cognitive processing therapy, as it won't surprise you to find out, focuses on thoughts, whereas prolonged exposure focuses on re-experiencing. So if you're looking at a prolonged exposure session, the patient or the client will be reliving the trauma, present tense thoughts and feelings, over and over and over again. And I tell you, it works. It's unbelievable how well that actually works. Once the therapist gets over their own hang-ups and helps the patient participate in it. CPT, on the other hand, doesn't really do that, but it identifies the kinds of unhelpful or untrue thoughts that the client or patient is stuck on. So these therapies always go to one of those two things, and you're doing exposure when you're talking about the thoughts too, because the thoughts come from the experience. Now, facing up is actually, in some ways, in my experience, even a little bit easier than dealing with stuck, unhelpful, untrue thoughts. I used to believe back in the day that if a kid came in and said, well, it was really my fault that happened, if I said, okay, it's not your fault, they'd say, thanks, I didn't know that. Problem solved. And then when it didn't work that well, I'd sort of say it again, louder, more times. And we have learned that that therapy is not for unhelpful and untrue thoughts. It's not the therapist just saying, here, don't think that, think this. It's a lot more complicated than that. There are a lot of reasons why people hold on to thoughts that aren't always that helpful or aren't true. I mean, everybody, we don't have to convince a patient that blaming themselves for victimization is not a great thing. They actually know that. So why don't they just say, you're right, it isn't my fault. There's got to be a reason why that thought is stuck and is serving a function. And I think it took our field a long time to develop the respect that we now have for thoughts that might not be true or might not be all that helpful, but stay with survivors for so long. And what I've come to understand is it's not my fault it might actually, that it is my fault gives the victim a sense, well, I have some control over. If I buy into your idea that I had nothing to do with it and it was not my fault in any way, that makes me less safe because I can't explain how this could happen. It could happen to me anytime, anyway. So the process of changing people's thoughts is a lot more complicated than the premise that changing the thoughts is an essential ingredient of recovering from a traumatic event. And it has to be a process in which the victim survivor, him or herself, comes to this new and better way. It cannot be the therapist doing it for the survivor or just simply telling them what they ought to be thinking instead of what they are thinking. Now, we're always looking for a new narrative that looks something like these kind of bullets that I've listed here. It happened to me, but it isn't me. Whatever I did or didn't do made sense. There was a reason for it. I have the utmost respect for every single thing every victim ever did in the context of their victimization, because they made a judgment about what would get them through that experience alive and in the best way. And it's just impossible for me as a therapist and someone outside to make a judgment about that. I always respect it. We'd also like to see survivors, when they can, find something about this experience that they gained, something, because otherwise it's a total loss. And in my experience, almost every victim has learned something about themselves that they can take with them, they can draw from it. If only in, I'm a strong person, I can take a lot of things. But that and so much more and so many times. So ultimately, at the end of the day, our goal in effective trauma treatment is to be able to help the survivor put the trauma in the past. That it is not defining their present, so that they can begin to look forward instead of back. And I heard that from all three survivors that spoke to us about one way or another the importance of being able to have a life in which you can look ahead without discounting or invalidating or pretending it didn't happen. It always did. But the future is what you can do something about, not only the past. And the past you cannot. Now, you also have heard, and of course it's true, that PTSD, while the most typical and most trauma-specific effect, it isn't the only one. It is not the only effect that we see in children who've been victimized. Some kids develop behavior problems, sexual and otherwise. And fortunately, again, we now have a whole collection of effective treatments for behavior problems in kids that work very well. I wanted to call out PCIT in particular, parent-child interaction therapy, because in addition to being an extremely effective treatment for behavior problems, they are actually demonstrating that it helps with trauma symptoms as well. So it's not simply improving kids' behavior, but it's also reducing their anxiety and traumatic stress symptoms. I think we believe the reason for that is that all effective treatments for behavior problems in kids are targeting the parent-child relationship. The whole idea is to change up the parent-child relationship so that there's more warmth, there's more closeness, because when that's true, kids want to be good. And then to teach parents to be present, consistent, predictable, and nonviolent. Well, I think it stands to reason that in a parent-child relationship like that, children will not only behave better, but they're going to feel more secure. They're going to be less distressed and anxious. So, and PCIT people are demonstrating that. Now, another specific problem for sexual abuse is the sexual behavior problem. And of course, there's nothing that really gets on our nerves more than the degree to which people are taking a misbehavior in kids and labeling it as offending behavior. I think my head is going to blow off when I get these phone calls like I did the other day from a teacher, a very concerned teacher, wanting to know what to do about the 4-year-old predator. I mean, I want to go right through the phone and start misbehaving myself. Because the very idea that you would think of a 4-year-old who did some weird sexual thing with another 4-year-old as a predator, that's just so unbelievable to me. And I really have to realize that people like me are kind of in part to blame for that. We've been excessively successful in establishing an attitude and a no tolerance for sexual misbehavior. All good. But when we start to apply that to children who are misbehaving because they've had an experience they can't integrate developmentally, or they have been reinforced inappropriately for other behaviors, and labeling them, and really, don't let people do that. Don't let anyone refer to a 7 or an 8-year-old as a predator or a perpetrator or an offender. They're kids with problems. And I have to say, I was not being my very best non-reactive consultant on the phone to the teacher when I was trying to say, don't throw the kid out of the preschool. How about keeping an eye on him? And I said, well, would you be calling me up if he had gone and punched another 4-year-old? What's the diff, We don't want kids touching other kids sexually. We don't want them hitting them. So I really feel strongly, as you can tell, that it's no help to a sexually abused child. Of the about 1/3 of them who might have some sexualized behavior, almost none of it involving being sexually aggressive, by the way, to label them or treat them as if they now are on some sort of a pathway into offending. We have a treatment that is unbelievably effective. You can see the randomized trial of treatment with children with sexual behavior problems. That study reports, that's a 12-session cognitive behavioral therapy. It teaches kids, here are the sexual behavior rules. Here's a skill to use when you are thinking of misbehaving. Hey, parents, keep an eye on your kids and reinforce appropriate behavior. The recidivism rate, if you want to call it recidivism, they have a 10-year follow-up, including official records, 2%. Just for comparison purposes, the 10-year follow-up rate of sexual misbehavior in kids who were seen for non-sexual behaviors, for oppositional behavior or attention behavior, 3%. So in other words, kids who get this treatment because they had sexual behavior problems have a rate of engaging in sexual misbehavior later that's no different than kids who never had a history of sexual misbehavior. So how good news is that? Then we have another set of mental health problems, conditions, concerns that some kids who've been sexually victimized experience, and these I think are trickier, and we know less about how to be effective, and we're a heck of a lot more worried about it, and that's the kids who get involved in these risky behaviors. And we know now kind of the pathway to that, and you heard about it from David and some of his data on risks for various outcomes in adolescence that we would really care a lot about, like early substance abuse, suicidality, being on the streets, involvement in prostitution. It turns out that one of the factors that makes a big difference is starting to be sexually active earlier. Penny, I think you showed that with your sexually abused girls, earlier onset of, and of course there is no direct relationship between sexual abuse and teenage pregnancy. It's all mediated by starting to be sexually active earlier. You have longer to be at risk and you're dumber about sexual relationships the younger you are in adolescence. So, and I don't know what we've done, how we've thought about what can we do to make more kids like Margaret? Put it off. You'll be better off in the long run because there's a lot of risks that go with that. Substance abuse, well, as David said, it's connected to a lot of bad things, puts people at very high risk. Victimization, almost every teenager we see who's been victimized has been involved in drinking and carrying on with kids who they don't know very well. And then, of course, the risky sexual behavior. I think, Penny, you talked about that as well. There's one treatment that I know of. It's risk reduction for substance abuse and trauma-related psychopathology. Carla Danielson at the Medical University of South Carolina has done a couple of studies where it's a modularized thing. So it addresses trauma, it addresses substance abuse, and it also addresses risky sexual behavior. I think we need to know more to help those at highest risk kids. And I'd say we're not as good as we need to be with those kids. So victims need treatment. Brief focused treatments can work, and I'm not saying that's the only thing that works or it's all that anyone wants. I know a lot of people, a lot of friends, colleagues, as well as patients who said they wanted a little different approach to therapy, a longer term, more relationship-oriented therapy. But I think it's important for people to understand that you don't need to have that to get better from PTSD and depression. You can go for these more structured treatments. There are a lot of good websites you can learn about it. and what the treatments look like and that sort of thing. And the new, brave new world is coming for therapy, where people won't even have to go to us. They'll just download an app. There's an app for that. We all have PTSD Coach on our smartphones. Check it out. It's fantastic. And so I don't know that going in to see the therapist is going to be the future. I think people will be able to cure themselves. So my final just take-home comments is I just want to reiterate a couple of points. One is this business that victims should get validation and acknowledgement regardless of how harmed they are, whether they have PTSD, whether they are depressed. Just having to go through that experience is something that warrants acknowledgement. And I've so many times had victims talk to me about if they're resilient or if they cure their PTSD, they get a drop off in support. Well, I guess it wasn't that bad. The badness has nothing to do with the harm or their resilience or their ability to cure themselves. Not everyone needs or wants therapy. I've been very impressed by how many victims and survivors are their own best therapists. My goal in therapy is to give them the tools to be their own best therapist going forward. So I don't think we need to take the everybody should go to therapy approach. I think we should have something to offer for people who want that. And of course, just the fact that so many victims, as we've seen here today, and we'll hear again from Elizabeth Smart, they've given so much back to us. We should be forever grateful. So thank you very much. It's lunchtime.
Oh, I think we have a few questions to ask first.
I really think that's risky. I mean, delaying the lunch hour has never been a good thing. So only a short one.
Okay, quickie. As you were talking, I looked up a couple of the programs you mentioned, trauma-focused CBT and processing,
Cognitive processing therapy.
And they're both there's training for both of those for clonicians that's free and online. Yeah.
Exactly.
And you can get continuing education credits for even. So along those lines, there are a question or two that are wondering what longitudinal study justify the thought that we can actually cure PTSD and that people won't have it anymore. Will they still have significant problems and difficulties in their lives? And are there areas of treatment that still need to be developed?
So let me be clear that, when you can cure PTSD, meaning you can have it and then you can not have it. That's not the same thing as recovery. Recovery is what victims do for themselves, and that is a whole different deal than getting a focused therapy for a particular psychological condition. So I guess I thank you for asking the questions, because I do not want to argue that doing therapy somehow makes it like it didn't happen, or it will never bother you, or there will never be another moment where you're reminded and it's hard. That's life. Therapy isn't that, well, maybe I'm giving away something, but therapy is really just a few hours you spend with somebody. I don't think we're that powerful, to be honest. I think we have tools and stuff we can offer to help people, but it's not, and I like the idea that we can say to somebody, you have it now and you won't have it 16 weeks from now if we work this deal together. That's hope, just to go back to what Chris said this morning, and that we believe in that. PTSD is anxiety disorders in general, you can be cured of them. Depression, much harder to be cured of. It's more or less a chronic relapsing condition, so part of therapy is learning to know when you're sliding and what you can do and how to be your own best therapist. But we're pretty good at curing anxiety disorders, meaning you aren't living with that terrible distress day in and day out. Most trauma survivors will have it happen again, where they're struck by the memory, or they have a reminder that really just knocks them flat for a while. But I have had the experience over the years, many experiences, where people will call me up and say, it's happening again. My PTSD is back. I feel like I'm going back to the beginning. And I always say, well, come on in. Let's see what happens. And they've never gone back to the beginning. It's just a bump, because they now know what it is and they know it can get better. So we don't mean to communicate that therapy takes away the fact of the experience and its enduring effect, but it can really cure the symptoms.
Okay, I won't risk asking you any more questions.
All right, lunch. Thanks.
Our